Welcome, everyone. I am happy to have you join us for our presentation today on the patient pathway to wound management with a focus on wound dressings. My name is Dot Weir. I'm a longtime wound care nurse, actually 42 years, and I currently practice at Saratoga Hospital Center for Wound Healing and Hyperbaric Medicine in beautiful Saratoga Springs. I am happy to be joined today by Kathy Milne and Emily Greenstein, friends from wound care, and they will tell you more about themselves when they start. These are our disclosures. And this is a disclosure that I'll read. The faculty have been informed of their responsibility to disclose to the audience if they will be discussing off-label or investigational uses of drugs, products, and or devices, anything that's not approved by the US FDA. And I will have one, and I'll bring that up. So the applicable CME staff have no relationships to disclose relating to the subject matter of this activity, and it has been independently reviewed for balance. So our learning objectives today are really just to do a case-based look, explore cases that illustrate dressing approaches to managing chronic wounds in various practice settings and various wound conditions. So I'm going to start off with just a little introduction. It's hard to succinctly and quickly talk about how we make dressing selections, but I've put together a few slides that I think it always helps me as I think about it. So when we look at what we want our outcomes to be with the dressings that we choose, when we think about what we want our end game to be, we're always going to want to make sure, and I'm going to put this again more succinctly in just a moment, obliterate or fill any dead space, making sure we're absorbing exudate adequately so that we can protect the peri-wound skin. We're always going to want to create that moist wound healing environment, with which some of the other speakers will talk about also. And by doing so, we can support autolytic debridement if that's one of our goals. We want to protect and insulate the wound bed, so we're not changing the temperature any more often than we have to. And then we want to protect the wound. We want to protect it from any kind of contamination from bacteria, as well as we want to leave the wound as undisturbed for as long as we possibly can. So it begs the question, what is the ideal dressing? Well, it's one that manages that exudate effectively. It doesn't dry things out. It doesn't overwet or macerate, and creates that perfect environment for healing. One that allows for gas exchange, and that will be talked about in a little bit as far as vapor exchange. We want to be thermally insulating, as I've mentioned, impermeable to bacteria, free from any particles or anything we're going to leave behind that could either be a source of infection or provide a foreign body reaction in the wound. We want it to be, and this is critically important to me, this is one of the really important things, non-traumatic and non-painful or minimally painful on removal. And there is a way for us to provide non-painful dressing changes to patients. Importantly, it has to work, the dressing has to work with whatever support needs they have. If they're wearing wraps, multi-layer wraps, if they're wearing casts, for example, and it needs to be user-friendly, because it's not always a skilled wound care person who's changing these dressings, right? It could be a family member, it could be a child, and so, or you know, a child of the patient. And so we want to make sure it's as easy as possible, as well as the less we layer, the less costly that dressing is going to be. So in closing out on this little intro, and when we're going to address the dressing, we can ask ourselves basically 4 questions. Is the wound bed dry? Then we want to hydrate it. And we can use hydrogel impregnated gauze, hydrogel sheets, surfactants, hydrocolloid dressings, film dressings. We'll talk about some of these, but something that's going to add moisture. Is the wound bed draining? Then clearly we have to absorb that exudate. And we have lots of options. Calcium alginates, and those will be talked about. Gelling fiber dressings, foams will be talked about, super absorbers, and of course, negative pressure wound therapy. And if you look at this picture here, with that exudate that's penetrated all the way through that dressing, it looks like the dressing is doing a good job, but it's moving that exudate out laterally, so you can see maceration, and you can see some erosion of the skin surrounding it. So of course, we want to find something that will accept that exudate more effectively. If the dressing, if this wound has space in it, then we're going to want to fill it. We can fill it loosely with moist gauze. Usually that's going to be a temporary measure until we get some other products or dressings in to use for the patient. One of our calcium alginates or gelling fiber dressings, one of our super absorber dressings, and of course, negative pressure wound therapy. And all of these are combined with how much exudate is there. We're going to pack the wound and fill that space, but it has to absorb the exudate. And then last but not least, once it's all filled in and it's completely, we're now ready for epithelialization, there's lots of dressings that we can use, but we're still going to think about the exudate. We can use a calcium alginate still if it's still draining a lot, a hydrocolloid or a film dressing, a foam, again, a super absorber, or a collagen dressing, which I'll be talking about. And so when you think about dressings, I always say it's the 4 Ds. Drainage drives dressing decisions. And I think that's what we'll be able to talk more about today. So with that, I'm going to turn it over to my friend, Kathy Milne, to continue to talk about products.
Thank you very much, Dot. So I am going to be talking about transparent film dressings. And so the history is pretty interesting because our ancestors used cod swim bladders to cover their wounds. And then what they eventually ended up doing was manipulating it called it isinglass plaster. And they actually used it over skin grafts in the 18th century. So I think that's pretty interesting. And as time went on with transparent film dressings, they started using solvents and over cotton, and they dried them on glass sheets. And then they started doing all this chemistry, right? So they added, sulfuric acid or nitric acid, and then a whole bunch of other different acids, including balsam or castor oil. And then what that did was made things very, very clear so they could see through that. Now, fast forward, okay, so the word cellophane means cello from cellulose, so plant fiber, and phane meaning transparent. So you can see here in the early 1920s, so a century ago, they actually found that cellophane offered faster healing and lower infection rates. Why is that probably happening? Because you had something that was semi-occlusive or occlusive at that point that actually kept moisture in. So this was way before Dr. Winters came in. And then you could see that the pioneer here was Dr. Elder, who actually used cellophane on his own burn. It healed great. And then he was touted it to the entire world about how great this was. And in fact, it was incorporated in World War II. And then we kind of forgot about it. And then in 1970, we actually started to see polyurethane, which is a different type of material, and they added an adhesive to it. So what should a transparent film dressing do? Well, it's got to be transparent, right? And it should stick to the surrounding skin, but not the wound. You've got to be able to get it on, get it off without a lot of pain. You've got to be able to have it stretch so it's over a joint, you can use it. And you should be able to have water vapor come through, but prevent bacteria from going in. And that would obviously allow some gas exchange. So some of the things you should know is that the flexibility of transparent film dressings and moisture vapor permeability is impacted by how thick the dressing is. Now, these things are really, really thin, anywhere between 0.45 and 0.75 millimeters thick. And that includes the adhesive layer that's on it. And if you remove it, it's obviously, you can see how thin it is there. Now, when you have a thicker transparent film dressing, they don't conform as well and they don't stretch as much. Now, moisture vapor transmission rate is really the major factor in performance, right? Because you don't want the wound moisture to accumulate on underneath the transparent film dressing and have this big, huge bubble that the moisture will eventually seep out and onto the peri-wound skin. So when we're talking about moisture, what are we really talking about? We're really talking about evaporative loss, the moisture vapor, gas vapor. And we're also talking about the wound exudate and water, and then everything that's around that wound, including, sweat and oils from your sebaceous gland. And then what we also found is that if you put it in a contiguous adhesive across your transparent, film dressing, you're actually going to lower your moisture vapor transmission rate because the adhesive includes all that moisture vapor from leaving, right? But if you just sprinkle it on, so it's called discontinuous application, you actually can improve your moisture vapor transmission rate. So when you ask a sales rep, what's your moisture vapor transmission rate, the higher it is, the more discontinuous that adhesive most likely is. So there are a lot of clinical uses here. So we are very familiar with this. This is an older, oldie but goodie dressing, and it does do well for covering IV sites and minor abrasions, skin graft donor sites, although really early on, those things ooze quite a bit. So probably not your first choice. We have seen people use this in COVID, especially, proning, trying to keep things from rubbing and friction. We do see it a lot in post-tattoo application. Now, this is what people hate about transparent film dressings, right? Is removing the dressing, because you have to break up that adhesive bond that's holding that transparent film in place. So what we typically want to do is we want to lift up like we do with a Band-Aid, right? And when you do that, especially when somebody is older, you're going to actually separate the epidermal dermal layer junction and actually possibly cause a skin tear. So it's a little not intuitive, but what you want to do is stretch it parallel to the skin, almost cause parallel wrinkles. And you can see this example here. And you want to stretch in the direction of the hair growth. When you do it this way, it does not hurt, but please tell the patient, when I stretch this, it may snap and it may break into little pieces. I'm planning on doing this. Otherwise, they think you don't know what you're doing because it does snap and break a little bit. So, but that is going to save their skin. So this is something you would probably want to use a transparent film dressing on. We did. This is a small cancer in a 103-year-old patient in a nursing home. This patient would pick at her leg cancer. They weren't going to do anything about it. We didn't even biopsy. The family just said, leave it alone. And the only way we could leave it alone is if the patient left it alone. So we put a transparent dressing over it. We could see the wound, and she stopped playing with it. So more importantly, I think a lot of us, this is a resource poor patient of mine who does not have a home, walks around all day in sneakers, whatever he can find hanging around in the area. And he came one day with a blister, right? So you have to protect the area from his normal environmental habits. So we actually used a transparent film dressing and let him go on his way. And you could see by week 3, it's smaller. Very easy to put on. We could take a look at it. He could look at it if he felt like he needed to, and we weren't getting that constant friction from the sneaker he was on. And here he is, day 6. He's got a little dry desquamation here, but he's all healed up. This is a patient who actually had some friction from the elastic in her brief at the that she was wearing for her incontinence. And you could see that, again, once we put the transparent film on, we were able to stop the friction from occurring and then able to heal this wound within 3 weeks. So really, you want to cover and protect after the wound is healed, especially if you have friction still going on and you still need to address that question or issue. So there are other tips for uses, and you can see here you can use transparent film for securement devices. And that can be really helpful, especially because some of the devices that are currently out there, when you're proning them, actually can cause pressure injury. You're searching around for tape, can't find any tape. We've been known to grab our transparent film out of our pocket and say, hey, we'll just throw this on. I'll be able to label it and move on and still look for that tape at some point during my travels. And then also I have a tendency to use transparent film dressings with when I have leaks in my negative pressure. I think what you'll see is the new drapes that are out there, the Dermatec drape, that actually won't need anything like that because it's a completely different material. It is silicone, so you can lift it up and put it back down within the first 20 minutes. And so, but here, have a leak, we can seal a little one without plastering 3 yards of drape over the patient. And then other tips for use, I also use it to mark after I do an ostomy mark, I actually cover it with a transparent film dressing. That way the patients can shower before their operative procedure. Okay, let's move on to foams. They've gone through a renovation themselves. So we first started seeing foams as a polyurethane, and then they got borders. And then we started seeing hydrocellular foams come out to the market with and without borders. And then the newest one, which actually is not even that new anymore, is silicone foam with and without border. But what we're seeing is really the difference in the silicone itself, because not all silicones are the same. We're seeing foam used to be single layer, and now we have the data that's basically urging people to use a multi-layer foam for a number of reasons, especially in the protection for pressure injury, prevention of pressure injury. So really, we think of foams as losing the ooze, right? We've got to get rid of this. So the ideal foam dressing actually does a lot of things very similar to a transparent film. You do want it vapor permeable. You want it painless. You want it easy on, easy off. You want to keep all the contaminants from the environment out. You want to be able to handle the exudate, right? And that's probably one of the most important. So when you see that chart over on the right-hand side, absorbency and moisture vapor transmission rate will be different between foams. So you want to ask for that data. Now, the whole is always greater than the part of its sums. So you need to think about how you're going to apply the foam dressing. How much drainage is it going to incur? Does it, does it have any silicone? Is it low friction? So the 3M silicone foam dressing actually has a silicone contact layer, again, making it painless for application and removal. So you have a good tack on the peri-wound skin, but you're not going to stick to the wound itself. The holes in it of this dressing are large enough to allow viscous exudate to come through, rather than the really, really tiny holes in other dressings that will allow a lot more watery exudate, but not that viscous stuff. So this has a little bit larger holes in the silicone. Now, the foam layer actually does some thermal insulation, which is good for our cells to move and divide. It doesn't shed the fibers. And again, because the foam will actually wick everything up and off of that wound bed and then transfer the vapor further up. And then it goes to that super absorbent layer, because this is where the rubber meets the road. You've got to hold that exudate in. We don't want to be changing dressings every day, twice a day. We really want a 3 to 5 day wear time for a lot of our patients. So that super absorbent layer allows you to do that. And again, it's vapor permeable. And then actually the outer part is most important too, because a lot of these dressings are placed in the sacral area where there's a lot of fecal contamination. You would just want to be able to wipe that off. And you can do that because of this outer layer. But also it's got a low coefficient of friction. So that actually prevents that shearing motion that you see that actually can contribute to pressure injury. And then the parts. So easy to apply, with and without border. And the nice thing about this, and it's also a little not as quite as intuitive as we would all like, is that that blue application. So you don't have to be trying to struggle with this little tape thing on the outside. Once it's in place, you just pull up on the blue. So think how we think about VAC is 1, 2 blue. So think of this as, 1, 2, apply and remove the blue. And once you do it once, you'll never forget how to do it. It's really easy. And so I want to give you some practical pearls here. You want to fold this like a taco when you're in the sacral cleft or the natal cleft, depending on where you are in the country, what you call that. So because if you don't stretch your patient out and you don't fold it, you're going to have what I call the poop shoot. So you want to fold it and mold it. And remember this dressing you can use also around the lateral foot. Remember 1, 2 blue. And again, once you do those blue tabs, you'll never forget how to do it. It's so easy. So this is a patient who underwent an IND, had a 5-day course of antibiotics, and then they had put her on wet to dry saline. We changed this actually to a silver gelling fiber to pack the wound bed and line the wound bed, but we put her on a silicone foam. And the issue is that she needed a shower. She goes, I need to do dishes. I need to shower. So the silicone foam dressing actually gave her that ability to wash the dishes and to take a shower. On day 14, we used a monofilament pad to get some of that debris up. And then we just changed it to the silicone foam dressing. You can see by day 28, she did really, really well. She started to shrink on up. And day 42 completely healed. I want to note that scar. The scar is really not very prominent, which we do know from the burn literature that silicone does reduce or enhances the appearance of the scar or reduces the scar appearance, depending on how you want to look at things. Glass half full, glass half empty. So, and as a summary, you really need to want to know the specs of your dressing. So go ahead and ask questions of your sales rep. You know, what's that moisture vapor transmission rate? How much exudate does it hold? When you're thinking of exudate, is it viscous exudate or is it thicker exudate? And you want to individualize the dressing needs to the patient's needs, like I need a shower, and the needs of the wound. And silicone foam dressings and transparent film dressings do have a role in wound management, so don't hesitate to use them. Thank you so much.
Well, thanks, Kathy. I've spoken with you so many times, and you always bring out such great and new information. So I'm going to spend a little time now talking about the use of collagen dressings and ORC collagen dressings, because they're a very versatile part of our repertoire of dressings that we can use. When we think about collagen wound dressings, collagen in itself is a biologically derived material. And as you probably know, the source can vary. It can come from cows, from pigs, from sheep, and a variety of different sources, because mammalian collagen is all the same. So our body recognizes it as collagen. It is, of course, the primary structural protein in our bodies. An interesting quality about it, when we use it as a dressing, it is bioresorbable. In other words, it degrades or it breaks down. A critically important part about collagen, though, is that it's not a moisture management dressing. We don't use collagen to manage exudate. They simply don't absorb. So it's used a little bit later, which I'll talk about. But the role of collagen in our wound care is to help guide tissue ingrowth. It helps to attract cells to the wound site. It forms a scaffolding, and it makes it attractive for cells to migrate in and attach to. Absolutely. As a result of that, it can help to increase the cellular proliferation at the site. But a really important function of collagen is that it helps us to sort of modulate the effects of matrix metalloproteases by acting as a sacrificial substrate. And I'm going to talk more about that. So, you know, in a perfect world, we would have a dipstick that we could put into the wound and say, well, if I think I have a hostile environment, like too many matrix metalloproteases, which I'll talk more about, it would be nice if we had a dipstick that we could put into the wound and then say, oh, the level is perfect, or no, it's getting up there, or don't even think about it. The interesting thing about this slide is that I made this back in 2004. And about 5 or 6 years later, there actually was sort of a dipstick indicator for both metalloproteases as well as bacterial proteases. Unfortunately, we don't have them here in the United States, but they are a tool that some people are able to use. So in an imperfect world, we have our assessment. I mean, we can check out absolute information such as the oxygen level, perfusion, our cultures, our labs, our x-rays, you know, our eyes and our nose in terms of doing our wound assessment and looking for clinical signs and things that are changing on the wound. But many times the wound may not look horrible. And so we begin a trial and error. I'll call it best guess, but it's really more of a trial and error use of dressings to try to find something that's going to change the trajectory of that wound. So matrix metalloproteases, I'm sure you're familiar with them. They're a family of protein degrading enzymes. And a lot of people think of them as something bad, but they're really not. They're necessary for wound repair to be accomplished. They're structurally related. There's about 23 known ones in the human body. These are just some other information about them. But they're really a critically important part of wound repair. They're synthesized by different kinds of cells, neutrophils and macrophages when they, during the inflammatory phase, are breaking down and killing bacteria. The MMPs, they will help to clean up the debris. Fibroblasts will synthesize an MMP in order to migrate through tissue. It has to move protein out of the way, so a proteinase allows them to do that. Endothelial cells, when they need to migrate out of those adjacent capillaries to form new loops of blood vessels, then they have to, again, migrate through tissue, migrate through that basement membrane of the vessel in order to do that. They use an MMP. And then epithelial cells, when we're just waiting for that wound to resurface, they have to cleave themselves away from their attachments, their hemidesmosomes and desmosomes, so that they can be free to migrate out. So they're really, really important. And they do this in response to signaling. And so in many physiologic processes, MMPs are a very important part of that. But something has to turn them off. And so where we have about 23 known MMPs, we have 4 tissue inhibitors that can bind to more than one type of MMP. So if they're cranking out the MMPs, they've done their job, then they secrete an inhibitor and it stops the process. So it's really such a critically important, well-balanced system. So you have tissue that's being made and coordinated by the growth factors, and then you have tissue that's being broken down at the appropriate rates by the MMPs. And so if it's all in balance, then the wound should be healing. The challenge that we run into with our chronic wounds, of course, are those that are not healing. And many times it's because of the hostile environment caused by the presence of those proteases. So as we look at this whole sacrificial substrate story, when tissue injury occurs, collagen is going to be synthesized and replaced by fibroblasts. But in a chronic wound, the signaling for fibroblasts occurs from growth factors, which are proteins. And in this hostile wound environment, they will also be broken down. Collagen will also then be degraded. So if there's an abundance of collagen, then the MMPs have something else to work on, and they will leave the native collagen of the wound alone. So delivery of this collagen can act as that low-hanging fruit to keep the MMPs busy and leave the collagen and the proteins of the wound alone. So we talked about the sacrificial substrate, but the other interesting thing that happens in this study, this work has been done looking at ORC collagen, is that it also can protect growth factors because by modulating the protease activity, certainly. But the other thing that ORC collagen will do is bind to growth factors. And then as the collagen biodegrades, they release the growth factors back into the wound unharmed. So it helps to not only modify and quiesce that hostile environment, but also protect those growth factors. So I'm going to share a few patients with you looking at how we use collagen dressings. This is a gentleman who was 63 years old, had previous this is his third venous leg ulcer. His peri-wound skin when he arrived was macerated. It was very thick and scarred. So we proceeded with just absorbent dressings of a variety and a 2-layer wrap. So this is after 4 months. And I mean, it's improved a little bit, but we started having this granulation tissue that did not look really healthy. And so we continued with it. We've been treating it, as I mentioned, with a 2-layer wrap, a variety of different dressings. And so the wound surface, if you'll just look at it, it's granular, but it's not real robust. It's not real healthy. It's almost hypergranulated. And so we used an ORC collagen. I double layered it because I was going to be putting it under the 2-layer wrap for a full week. And this is 1 week later. And so again, I didn't have that dipstick to tell me what was going on. I could just tell it was a bad environment, and that ORC collagen was able to change that environment. And then once we reduced and got rid of that hostile wound environment, it went on to close. Another interesting one. This is a gentleman that had a trauma in his workplace. He's a landscape worker, and so he had this avulsion, large wound. He was otherwise pretty healthy. We used negative pressure wound therapy to get it to fill in, and then it was doing okay, but again, sort of came to a standstill. And so what we started noticing is that the wound edges did not look healthy. I'm going to blow this up a little bit. Now, this was after an ultrasonic debridement, but it doesn't lift edges up like this. So it seemed like the epithelial cells were not attaching well to the wound bed. So we began the ORC collagen dressing, and in 18 days, he went on to heal. So you see what I mean? It's not like you have any way of knowing this, but just that using the ORC collagen, we can many times change the wound bed in two ways: by reducing the sacrificial substrates, as well as protecting from the, encouraging the growth of new tissue. My last case I'm going to go through pretty quickly, but it's an interesting one. This was a gentleman who had a Mohs surgery for a squamous cell cancer of his head. This is how he presented to us. We did an ultrasonic debridement, began ORC collagen in the clinic. And one of the things about collagen is we want to moisten it when we put it on and make sure it's quite a nice moist environment in the wound bed. So they weren't moistening it at home before they would put it on. So we cleaned him up again. And as we got him cleaner, but then we began to see part of his skull exposed. But you'll notice it's pretty healthy bone. There's actually granulation buds on top of it. He did have an MRI. It was negative. And so what we did in this case, and this is off-label use of this gel, is we added a PDF gel to the collagen. And this is something that I've done many times in the past because of the knowledge that it will bind up the growth factors and then slow release them back into the wound bed. That's just my statements, nobody else's claim. But if you look what happened on day 24, tremendously granulated. There was still a little bit of bone exposed on day 30, and we were thinking we were going to try to put on some sort of a skin graft, but we continued with the ORC collagen, and he went on to close. And we actually saw this man about 5 years later for another kind of wound, and he had remained closed. So that's where I'm going to stop with collagen. I hope it made some sense to you. And it's my pleasure now to turn it over to Emily to talk about exudate management solutions.
Thank you, Dot, for that great presentation. My name is Emily Greenstein, and I'm going to talk to you today about exudate management solutions. So first of all, we need to identify what is exudate. So exudate is fluid that is leaked out of blood vessels. It's a natural healing mechanism in acute wounds. In chronic wounds, oftentimes exudate is highly alkalinic, which impedes healing. It can be difficult to manage. If poorly managed, it can cause that maceration, peri-wound skin breakdown. It can cause pain and distress to our patients. It can also cause the wounds themselves to enlarge. When we talk about exudate, not all exudate is considered bad. There is good exudate and there's bad exudate. So when is exudate good? Exudate is good when it provides a moist wound healing environment. It enables that diffusion of immune mediators and growth factors. It acts as a medium for migration of tissue repairing cells. So if you think about it, when our body gets injured and we look at the healing cascade, our body activates the immune process where our cytokines come, our mediators come, and that exudate is essential for providing a pathway for those to get there. It supplies essential nutrients for cell metabolism and promotes the separation of dead or damaged tissue through the process of autolysis. So if you've ever heard of autolytic debridement, this is where that comes into play. So our body's natural fluids are helping to break up and separate that dead, necrotic, or sloughy tissue. When we talk about exudate being bad, it's bad when it's in the wrong amount. So meaning you either have a copious amount, it's draining too much, or if it's not draining enough, if the wound is too dry. And then in the wrong place, meaning is it draining downward into a crevice? Is it draining into a distal location? And then the wrong composition. Is it infectious? Is that exudate actually infectious that we are seeing? We talk about the components of exudate. Exudate is primarily made up of water, fibrin, microorganisms, electrolytes, nutrients, those inflammatory mediators like I just talked about, white cells, proteases, growth factors, and then some byproducts or waste products also. This kind of, you have to really think about going back to your pathophysiology when we talk about the formation of exudate. So the formation of exudate starts by interstitial fluid balance. So that hydrostatic pressure, your oncotic pressure, and then the permeability of this capillary wall. So this graph kind of shows us the role of inflammation in exudate production. So we know that when there's localized or generated inflammation affecting a wound, there's a release of those mediators and enzymes. So like I said before, you get an injury, you get a wound, what happens is those mediators are released. There's vasodilation and increased capillary pressure at that point. There's a breakdown of endothelial cells, a disruption of the glycocalyx, and then a breakdown of reduced stiffness of the extracellular matrix pressure. All of that causes the filtration of fluid, proteins, and cells to be increased. That results in an increase of interstitial fluid, which results in wound exudate. It also results in a decrease of lymph flow, which increases that interstitial fluid too. So if you kind of think about this in the big picture, we get a wound, we have decreased lymph flow, so that fluid is just sitting in there, and that's when you're going to start to see a lot of that edema or peri-wound edema that you might see in wounds that are highly exudative. So when we talk about acute versus chronic exudate, chronic wounds have high levels of inflammatory molecules, like you had heard in the previous presentations when Dot talked about the high MMPs in these wounds and raised protease activities and how we combat those with the use of some collagen. There's lower growth factors in chronic wounds. There's a lower mitogenic activity. So there's basically, that just means there's a less ability of wound exudate to stimulate fibroblast proliferation. When we classify wound exudate, we can classify it based on color and consistency. The color of exudate can range anywhere from clear to red to tan to green. The consistency can range from watery to very thick and creamy. As you see in this picture here, this is an example of a patient who actually had a lymph leak in her hip after a total hip arthroplasty. And you can see the clear fluid that's kind of yellow tinged, that is when draining in copious amounts from an area that's close to the lymphatic system. Oftentimes that is considered a lymph leak. You'll see those in groin incisions. You might see them after total hips, like in this case. Next, we can classify wound exudate based on the type. So when we call it serous, this is that clear watery fluid. It has few cells. It consists mostly of serum derived from the blood and serous membrane of the body. You can have serosanguinous. This is probably the most common type of wound exudate that we'll see. This is that thin pink. What this is a mixture of serum and red blood cells. You can have a fluid that's sanguinous. This is thin and bright red, or it can be hemorrhagic. Large amounts of red blood cells indicate damage to the capillaries. So this is your active bleeding. You can have drainage that's purulent, which is thick or thin. It's tan to yellow. This is usually made up of leukocytes, dead tissue debris, and then dead and living bacteria. So how do we know there's purulence versus necrotic tissue? Oftentimes we'll get consulted for a patient and it'll say purulent drainage coming from their wound. Well, we go and see them and it's really not purulent drainage. It's actually slough or necrotic tissue that is within the wound bed. You can see in these two examples that the 1 foot, that's just slough or dead necrotic tissue within that wound bed, whereas the fasciotomy site for necrotizing fasciitis has frank pus within the cell walls. So one kind of tip or trick that you can do if you're kind of like, is that slough or is that purulent drainage, is to go ahead and irrigate the wound out. After you've irrigated, if you're able to expel more purulent drainage out of the wound, then it's purulent. If it kind of wipes away and it's just that stringy looking necrotic tissue, that's more than likely slough. We also document wound exudate amounts. So amounts range from none to copious. We document the amount. You can have a scant amount, which is the wound is moist, but it's not really draining. Minimal to moderate, it's easily managed with standard dressings. And then when you talk about getting into the large or copious amounts, that's where we need to bring in our specialty dressings to manage this type of exudate. These are often difficult to manage with any dressing. Oftentimes this is affects our patients' activities of daily living. They often complain they can't leave their house because their legs or their wound is weeping all over. So when we look at factors that might alter exudate production, we can consider stages of the wound healing. So is this wound in the inflammatory stage of normal healing versus the end of the healing process? When you're in that beginning inflammatory phase, you're going to see a lot more exudate production just because of those cells that are getting, those mediators that are getting called to the site of injury. We look at local factors. Is there an infection or biofilm present? Is there any foreign body within the wound bed? Is there any edema or that peri-wound swelling? Is there a tumor present, a fistula? Is there a presence of eschar or ischemia? Because those types of wounds are a lot drier. And then the wound type itself. So do you have a venous stasis ulcer? Venous ulcers tend to be more exudative than, say, arterial ulcers. Those are a lot more dry. Looking at the location of the wound. Is it on a distal extremity that has a lot of edema? And then systemic factors. Is the patient in chronic heart failure? Do they have exacerbation of heart failure? Are they in renal failure? Are they a dialysis patient? Do they have fluid overload? Are they malnourished? When we talk about being malnourished, what happens is a lot of times if your albumin is low, the fluid isn't held within the cells, it's released into the interstitial fluid there. So you'll get that third spacing or more edema in these types of patients. What systemic medications are they on? Are there any endocrine diseases present? Is the patient at an advanced age? We know patients that are on both spectrums. Are they really old or are they really young? Those two types of patients are really high risk for dehydration. They lose fluid a lot faster. Are there any raised C-reactive protein which can indicate a inflammatory response or infection? Is the patient dehydrated? Are they in hypovolemic shock? Is their overall fluid lower? Other factors that can affect is positioning. Like I said, is it further away on the body? Is the patient using any heat or ice to that area? And then inappropriate dressing selection. Are they using a dressing that is adding moisture to an already moist wound? And then patient compliance. Are they changing their dressing appropriately like they're supposed to? Are they coming to appointments? Are they elevating their extremities that are very edematous? Are they wearing compression? These factors will play into the amount of exudate production as well. When we talk about the importance of a moist wound healing environment, we know that insufficient moisture in exposed tissue causes desiccation, cellular death, and can prevent epithelial migration. This is why the cornerstone of chronic wound healing is a moist wound healing environment. Excessive moisture due to exudate inhibits cell proliferation and breaks down matrix components. This is why we can't have a wound that's heavily draining continuously. It's kind of a fine line in moisture balance in a wound bed. And how we achieve that moisture balance is through the appropriate choice of advanced wound care dressings. So I kind of like to think about it like Goldilocks syndrome. So do you have a wound that is too dry? Do you have a wound that is too wet? Or do you have a wound that is just right? So in the first picture, the ones that's too dry, healing has become impaired. And the wound that's too wet, you can see healing is impaired because you have a large area of maceration around the wound, which can result in the wound enlarging itself. And then in the final picture where it's just right, you have a wound bed that is nice and granular. You have peri-wound skin that's intact. So how do wounds lose moisture? They lose moisture two ways: via exudate production, which is the liquid that's the exudate that's produced, and via evaporation through vapor. Wound dressings should be able to absorb liquid as well as prevent moisture vapor loss from exposed wound tissue. A lot of times in different dressings, if you read on the back of them, you will hear a lot of talk about the moisture vapor transmission rate, or the MVTR. You want to look for a rate that's around 28.3 plus or minus 237.8 grams per meter squared over 24 hours. It provides an optimal moist healing environment. Most of our superabsorbents, our foam dressings, they're somewhere around that mark. It improves proliferation and function of the epidermal cells and fibroblasts. So as you can see from this picture, the ideal characteristics of a wound dressing: it's able to provide that wound healing environment, remove excessive exudate, which increases oxygen levels in the cell. and then it prevents microorganisms from entering into the wound. So we talk about exudate management solutions. Our super absorbent dressings are great for your wounds that are highly exudative or moderately exudating. They absorb and retain high levels of exudate. They sequester and retain bacteria and MMPs away from the wound bed, preventing the transmission and risk of infection. They're easy to apply. They come with or without an adhesive border. What these dressings do is they allow the exudate to be sucked into the dressing, and then they wick it vertically also. So the key component is a dressing that's wicking horizontally and vertically, so that the fluid stays within the dressing itself and is not on the wound bed or on that peri-wound skin. So our indications for the use of a superabsorbent is a primary dressing for full thickness wounds with moderate to heavy exudate, or shallow or deep wounds that are highly exudative. Contraindications would be our dry wounds. Obviously, we want to go back to that rule of thumb of moist wound healing environment. So if you have a dry wound, you wouldn't put something on it that's going to dry it out further. Utilization parameters, this I always like to put in there just so that you know that most insurances will cover the superabsorbents without an adhesive border up to once daily. The ones that have the adhesive border up to every other day. Now I'm going to show you and talk to you about a couple of cases. So this is the first case. It's a 65-year-old male. He had a history of venous stasis ulcers. He had a previous ablation. He does have controlled type 2 diabetes. His treatment plan was weekly multi-layer compression wraps, application of the ORC collagen to the wound base, and then a super absorbent pad and acrylic skin protectant to the peri-wound skin. One thing to note with these wounds that are a little bit more highly exudative, when you have the ORC, you can put that directly onto the wound dry. And I also end up fenestrating it so that the fluid can penetrate the ORC collagen a little bit better. And then the collagen is able to work its magic and control or decrease those MMPs. So you can see in the day 0 with this patient, the peri-wound skin was a little bit macerated. That is why we decided to go ahead and use the super absorbent, because he was only coming in to have the dressing changed once a week because he was in a multi-layer compression wrap. And you can see as the patient progressed, by day 35, he was almost healed. This is the next case. This is a male. He was 65. He actually had vasculitis. The area was biopsied. His treatment plan included weekly multi-layer compression wraps, a gelling silver hydrofiber with oxysalts, and then the super absorbent pad on top of that. So you can see in day 0, his wound was pretty heavily exudative. We used the gelling silver hydrofiber with oxysalts to help bring oxygen to that area and break up some of the necrotic tissue in the wound bed. You can see on day 7, he had quite a bit of exudate. It was interesting because you can see how the super absorbent pad sequestered that drainage and kept it within the wound, in the dressing itself, and didn't allow for it to cause problems back in the wound bed. This is case 3, so 56-year-old female. She has a chronic venous stasis ulcer with previous greater saphenous vein radiofrequency ablation. She also had her small saphenous vein treated. She developed 2 new ulcerations 2 years later. Her treatment plan included compression with a multi-layer compression wrap, wound bed preparation, including sharp debridement, peri-wound skin protection with a center-acrylate acrylic protectant, and then a variety of topical wound care products. So you can see with her, she had a lot of stasis changes. The problem with these venous ulcers is they might be tiny, but they are highly exudative. So we decided to use the super absorbent pad on her to help maintain or to help wick away that exudate. You can see from day 7, day 14, she did undergo a radiofrequency ablation of perforators in the area. And then by day 42, she was healed and transitioned to her compression stock. So this is case 4. It's a 56-year-old male. He had been a paraplegic for 33 years due to a motorcycle accident. He was incontinent, he was obese. He states that the ulcer originally started from a brown recluse spider bite 10 years prior. He lived at home with his wife. He was his mom's primary caregiver. His treatment plan included compression, wound bed preparation, peri-wound skin protection, and the use of the superabsorbent dressing. I kind of wanted to put his ultrasound results from his venous duplex to kind of give you an idea about how these work or what you want to look for. So when you see the report like this, what we look at is primarily the greater saphenous vein from the thigh down. So in this case of the patients, you can see that the diameter of his greater saphenous vein is 0.56 centimeters. Normal is less than 0.5 centimeters. But we also look at the refluxing time. So his refluxing time was 3,367 milliseconds. Anything over 800 milliseconds of reflux is considered pathogenic and should be treated. So what was happening with him, because his legs were dependent, because he's a paraplegic, he already has these vein problems and venous insufficiency. So he has increased venous hypertension. So fluid was coming down, but because the valves and the veins were not working efficiently, it was unable to pump that fluid back out, resulting in edema, resulting in this highly exudative wound that we see. So he did end up getting a venous ablation of his greater saphenous vein, but you can see in the picture with the use of the multi-layer compression system, the use of a superabsorbent dressing, and then a few other various dressings along with the superabsorbent pad, that by day 42, he was almost completely healed. Thank you for watching, and the Q&A portion will be up next.
Well, hello, everyone. This is Dot Weir, and I am joined by Kathy and Emily, and we're here today to answer your questions, and we appreciate, gosh, there's a whole bunch of you online, so we appreciate you joining us. I'll be running the Q&A and send these questions out to my other colleagues here. So let's get started. All right, so there were several questions about PDF gel. It's a PDGF gel. It is a pharmaceutical, and I do want to say again that our use of it on a scalp wound that I mentioned was off-label use. It is indicated for diabetic neuropathic foot ulcers. But anyway, it is the generic name, because it's a CE, is Becaplermin. It's a platelet-derived growth factor gel, and so you could Google that because there's only one on the market. In fact, you can't even get it right now. But it's a gel that is used for diabetic foot ulcers. All right, so let's go ahead and answer some of these questions. Emily, can you tell me more about oxysalts?
Sure. So the silver oxysalt dressing is a type of hydrofiber dressing that's available on the market that I utilize a lot for wounds that have a little bit more biofilm in them that appear to be more locally infected. And the reason is because of how the dressing is designed. What happens is when the silver and oxysalts get in contact with the exudate, it releases ions oxygen into the tissue bed. It creates basically a low-level hydrogen peroxide in the wound bed. So that allows for more oxygen to be delivered to the wound bed. It also allows for that necrotic tissue or slough to be broken up a little bit easier.
Right, thank you. Kathy, are there foam dressings that don't have a sticky pad?
Yes, there are a number of foams that don't have a sticky pad. So if we're talking about a non-bordered foam dressing, so the part of the dressing of that foam that goes onto the wound bed, so when you say non-sticky, that usually means that there is a silicone coating over that foam that will not adhere to the wound bed. So silicone actually is hydrophobic, so there's no it won't stick to moisture, and which is why we haven't really seen a lot of silicone dressings to be used on some of our patients that have a lot of areas with sweat. So in the old days, we used to use tape to, let's say, secure an NG tube to somebody's nose. And you would like to do that these days because of their proning, and you don't want to cause any skin damage. But the problem is that these people have sweat a lot, but the silicone with a lot of moisture won't stick. So, and that's the beauty of why we want to use this in a wound bed that has a lot of exudate. So that's really what you're looking for, is something that's not going to stick to the wound bed. So it's going to have a silicone interface at the wound bed. And then you also want the silicone to adhere to the surrounding intact skin. And that's the beauty of silicone, because it will stick to dry tissue very, very well.
Righty. Emily, what are your thoughts on the petrolatum gauze dressing? I don't think we addressed them, but if somebody has docs that are using that.
Sure. So petrolatum dressings I use a lot of times for underneath negative pressure wound therapy if I don't want the foam to stick to the wound bed. We use them a lot as contact layers. So if you have like a skin tear, you can use them over that. I guess that's probably the most common places that I use them, just because they can give the wound a little bit more moisture. And like I said, it's a non-contact layer, so it doesn't stick to the wound bed.
Yeah, that's definitely how I use it also. Kathy, what about the transparent film dressings that have a pad in them? What can they be used for?
So once again, I think you have to look at the composition of the pad. So if the pad has a non-contact layer associated with it, then that will not stick to the wound bed. If it does not have a layer that would be in contact with the wound, that would facilitate the drainage and exudate, and also the tissue growing into that wound or adhering to that pad, then that probably is not your best option for anything. They, we do use those transparent films with pads for a number of things. Usually, we put them over biopsy sites fairly often. They're easy to use. Biopsy sites don't ooze a whole lot, and you can get them off fairly easily.
All righty. And Emily, I'll ask you one more, then I'm going to address some collagen questions. Can all super absorbent dressings be left under compression for 7 days?
Not all of them are designed that way. When you're selecting a super absorbent that you're going to use underneath of a compression wrap, you really want to make sure that you have one that holds the moisture really good. Some of them will kind of balloon up or almost get like, how a diaper gets, where it gets a little puffy. Those ones, if you're able to squeeze the fluid back out of that dressing, those ones are not the best to use underneath compression wraps. So when you're selecting one, you want one that's going to hold the moisture in it and wick it away, and it's not going to be able to squeeze it back out into that wound.
Okay. All right. Let me address some of this on collagen. The frequency of change is interesting. Collagen biodegrades, as I mentioned, and the frequency or the rate at which it breaks down really can be a little bit diagnostic. Nobody makes that claim. But if I put a silicone, like an ORC collagen on, and I leave it, and it can be left for 3 days, and I go back 3 days, and it's completely gone, then it broke down really rapidly, so I might change it 2 days. If I go back in that same 3 days, and it's still a lot of that collagen material there, that tells me it's not biodegrading as rapidly, so I can increase the usage. So it really varies with the exudate, but also the number of MMPs that are used in the dressing. So the frequency would just depend on the exudate. As far as using anything under VAC therapy, somebody asked about using collagen powder. That would be off-label for the negative pressure device, but not necessarily for the collagen. So that would have to be just a decision that you make for your patient.
The FDA did just approve the ORC collagens to be used underneath negative pressure wound therapy.
OMG, thank you for that. I didn't know.
But like last week, So
Oh, okay. I don't feel like, is collagen daily a waste? Probably. If it's not biodegrading that rapidly, then it would probably be a waste. We're going to run out of time here. So I want to say one thing. For people who are asking about dressings, I would refer you to woundsource.com. That's woundsource.com. When you go to that site, you'll see every question that you could possibly have about dressings would be there. So that would be, for the person who I think is from outside the United States, that would be another source that I would go to. So let me see if there's a lot of these. What about using cyanoacrylates in the peri-wound skin? Emily or Kathy, either one.
I use them a lot.
Okay. Okay.
I use them a lot.
Yeah, the question was very product specific, but to keep it a little bit neutral. So, all right, I believe go ahead.
Oh, I was just going to say the cyanoacrylates are nice to use, especially under ones that are more highly exudating, because they will stay in place for a couple of days. Some of them are actually designed to stay in place. You can use under wraps and will last up to 7 days.
Thank you, everyone, for joining us. I wish we could have gotten all these questions. Please contact us directly if you have any questions that we can answer. Thanks for joining us.
Thanks.